Okay, thank you. Okay, hello. Hi.
Yeah, we can hear you, sir. Thank you.
Okay, thank you. Good morning. I'm NDV. I'm from Singapore. I've got a very good assistant on my right, Dr. Nitish, who's helping me make this surgery look easy.
Good morning, everyone.
Yep. Okay. Okay. Good. And today we are gonna do a regenerative augmentation of a rotator cuff repair. And I have, in the interest of time, we have created a tear, and we have also passed the medial row anchor through this rotator cuff. And I'm going to show you that in a short while. So that is our medium-sized rotator cuff tear. And if everyone can see, can we have some lights on the outside view so that everyone can understand what we are doing? Yep, excellent. So I've passed all my sutures, and you can see the sutures coming through the cuff. So that's the first two, and that's our third suture. Okay. Maybe just abduct that. Okay, so there's two sutures here, and there's actually two coming to the back of our, there, you can see that, okay?
There are two.
Okay, there are two sutures here, and we have passed all these through our rotator cuff, and we have put it through our medial row, and you can see that, and it's important now to make sure you capture the biceps. You can see there's a biceps through the rotator cuff. Okay, we are gonna now complete our lateral row anchor. Let's have the footprint. And then we're going to put the regenerative over. If you notice, can I have a pointer, maybe a awl?
Probe.
Yeah, the awl. So we can see these are the standard portals that we have made. We have a posterior anchor at the back right here. That's a posterior portal. And my scope is now in the posterolateral portal. It gives you a very nice view. I was just talking to Nitesh, and he loves this portal as well. It gives you almost like a lateral view of the rotator cuff tear, and yet you still have space for a lateral working portal. Okay, it's important that this lateral working portal is low down, so that you get a very good attack on the rotator cuff, and it gives you a good attack on the to the acromion if you are doing an acromioplasty. And then finally, we have an anterior superior portal that is coming right here, and that is the portal that I use to put in my medial row anchor. All right. So without further delay, I'm going to now retrieve all these sutures. Let's have a suture retriever on our, so Nitish, can you just stabilize that for me, thanks. Okay, so I'm going to retrieve the two blue sutures from the anterior part of the rotator cuff, and then I'm going to retrieve the two white suture, which is sitting right at the back of our shoulder right here. Okay?
Yeah.
Yeah, perhaps we could have spread that two white suture a little bit more if I would be highly critical. But that's our repair. So can I have the footprint anchor? So if you hold my camera for me.
Yeah.
Yep. Yes. And then we're going to pass this suture. So I'm going to complete my rotator cuff repair, hopefully in the next...
Hold the camera. Yes.
Hold it for me.
You can go there, you can help him actually with that. Yes.
Yep. Yeah, just give me a little bit of space. Because sometimes this... hold it. Yeah. Okay, let's have the first two sutures. Can someone help me? Yeah, bring it nearer. Yeah, maybe the two white first. And we are just passing our sutures through through our lateral row anchor. Okay, pull the foot. Slow. Yes. Yeah, maybe. Yep. Yeah. Okay, good. Okay, slow down. And then let's pass me the two blue. Two blue, yeah. No, two
Both of them,
together.
both of them, yes.
Yeah.
Okay.
Okay, yeah, that's fine. Yeah. Okay, I put it a little bit less. Okay, yeah. Okay, excellent. Can you tighten this? Oh, this
And you're just passing the sutures to the lateral anchor, right?
Yes, yes, I am. I'm just passing the sutures through the lateral row anchor. Yeah, and can you just tighten this for me? Okay, great. Yeah, can you tighten this? Okay, so once we have passed that, now we are going to complete our rotator cuff repair. So if someone can just hold this construct for me. Okay, excellent. I'll take over the camera.
Yeah.
Okay, let's have the awl now.
It's good.
Okay, and can I just have this view? Yeah.
Okay.
The golden awl. Yep, please stop me if there's any parts of the surgery that you all need clarification. Okay, but we are going to complete our rotator cuff repair now, and I'm just coming in with my awl. Can I have the camera? Yeah.
Now the lateral row anchor, how far down do you normally put it?
Yeah, okay, so typically I will put it somewhere about at least a cm down. All right, somewhere about there. Sometimes in the case of the Regenetan, I'll put it just a touch higher so that it's easy for me to see and it's easy for me to avoid. So once I'm happy there, okay, let's mallet this down.
But do you not find the bone to be very soft in that area?
Yeah, well, we'll find out in a short while. I find this quite a reasonable location, but this is really where the top is, so I'm very, very far from my medial row anchors. All right, so I find that the bone is a lot softer in there than somewhere out here on the lateral aspect of the anchor, or of the greater tuberosity, sorry. Can you hold my camera for me?
And you don't do knotted medial row?
I usually don't tie the knots if it's a simple balance repair because I want to avoid strangulation of the soft tissue. But I do think that there are merits as well to tying the knots. So I'm just trying to cinch down my sutures to complete the repair. Nitish, can you just help me pull them?
And just pull it.
Yeah, one by one.
One by one, okay.
Yeah, I got the camera now. Yeah. Yeah. Nice.
Okay.
Yeah. Okay, I think the cannula can back out now a little.
Okay.
Excellent. Okay, so that's us. So Nitish is going to just help me cinch the sutures one by one. Nitish, if you can just help me pull them
Okay.
one by one. Yeah, but you're right in saying that, we can, of course, tie our medial row anchors if we feel that it's necessary. Okay, yeah,
Yeah.
I think that's good.
Hammer.
Okay, good, yeah. Yep, all the way down.
Oh, perfect.
A
Yeah.
bit more, a bit more. Yeah, okay, good. Can you hold my camera for me? Yes. Okay, great. Okay, so that's our standard double row rotator cuff repair, and on the interest of time, I'm just going to use one anchor each. Okay, and,
Yeah, now. Yeah.
okay, and let's have a suture cutter. I'm just gonna.
Remove the central wall.
I don't think it can. I'm gonna take it down.
Okay.
So did you have instances when you felt that the hold is not so good on the lateral side and you had to reposition that?
Yeah, there are, of course. Sometimes that happens. And yeah, maybe this should help me cut this.
Should I do it?
Yeah.
Okay.
Yeah, you're right in saying that sometimes we do have instances where we feel that the bone is not great enough. and we have to reposition it. Sometimes I like to start with a smaller anchor if I can. So in the situations of a pull-out, in the situations of a pull-out, I sometimes upsize to a bigger anchor.
The only apprehension is
pull
that
this
you
out,
now
I
not knotting the medial side. You have a non-knotted medial
No,
side.
no, it's not coming.
And you're putting an anchor into the lateral side of the soft bone, and it can come out.
Oh yeah, okay, so that has
Like
just happened
that.
to us. Yeah,
I think the anchor has come out here.
yeah, okay.
Yeah, it has come out.
Yeah, okay. Let me have a all.
The bone is very soft.
Yes.
Average bone is a bit more softer.
Yeah.
So I think,
Yeah, give me a grasper. Yeah. Okay,
Scissor or something. Knife.
that's light. Okay. So, should I just put one more anchor in again? What do you all think? You may have a suture
No,
retriever.
no problem. You can go ahead, or you can just pass your threads and keep it as it is, and just demonstrate the patch insertion.
Yeah, because
that is what
I
is more important.
Yeah, correct.
Just hold it on
Lock-
lateral side.
suture retriever.
Don't put it as an anchor.
Yeah, okay.
Retrievers.
Give me a
Yes, grabber.
suture retriever.
This was the one. Suture retriever.
Suture retriever. Oh, sorry, grasper.
Grasper, right? No, this is not the one. This is
Yeah, our sutures are a little bit short, unfortunately, in this case. I'm just going to retrieve these sutures. Maybe can I have a individual suture with a first pass loaded on it? I'll just pass it down onto an anchor. Okay, yeah, just load the free suture. Okay, so in the interest of time, no need, I think,
Okay.
let's have a first pass.
first pass.
First pass with a suture. There's a free suture earlier on. Okay, yeah, I'm just going to pass a suture and assume this is actually through our medial row because I really want to show the regeneratant. Is that okay? Excellent.
Yeah,
So
that
let's
should be okay.
Yeah, okay, let's put it out. Okay, let's have the footprint again, maybe.
Footprint anchor.
Yeah, do you have a bigger footprint anchor? Yeah, helicoid knotless as well. Is it possible? Yeah, Nitish, if you don't mind just helping me put this through.
Yeah.
Yeah, so typically I will do a medial row and a lateral row anchor. This cadaver bone is a little bit soft. Yeah. So I'm just going to make this assumption that these sutures are actually through a medial row anchor. Yeah. Okay. And just help me pull the suture a little bit tighter, one by one. Okay, good. Okay,
yeah,
good. Okay, good. All right. Okay.
Hammer.
Yeah. Mallet. You turn it mallet first, right? Okay. 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 And then turn one. Yeah.
I think it's not going inside. Now it's going inside, yes. Okay.
No. No. Yeah.
Yeah, now it's going, yes. Okay.
Yeah. I got the camera. You can let go of the camera, please. Okay. Okay. The bone is soft. Yeah, the bone is quite soft, so my anchor is going right into the bone, so I really hope this gets there. Okay, good. Oh, no.
No, this anchor is bone.
Yeah.
Bone is very soft. We take a bite lower down.
Yes.
Probably.
Okay, so let's take these sutures out again.
Take it out?
But it's locked already, right?
We'll take more anterior.
No, it will come out, yes.
Okay, good. Okay, let's have all again, please. Okay, let's pull it up there. Good. So I'm going to go just a little bit lower down. Hopefully we are lucky enough to find some hard bone here. Okay, good. Mallet, please. Yep. Okay.
I think don't go fully with the trocar.
Yeah, I think so.
Yeah.
Okay, let's try that one more time.
Yeah.
Do we have another helicoid knotless? It's the same
Do
one.
we have another one?
Do you have another helicoid knotless, please?
Yeah.
Yep, I'm just going to leave this here so that we recognize the hole. Okay. And after this, we need the cannula for the heat, the regenerate.
Nice.
Okay, great. Okay, great. Okay, good. So again, I'm gonna hold this. Okay,
I'll just pull it. a bit.
yeah, just a little bit of tension. Yeah,
Okay.
nice.
Yeah, I think that's the
Okay,
maximum.
good,
Yes.
excellent. So let's have the mallet, please.
Hammer? Mallet?
Yep. Okay. Okay, excellent. Okay, can someone hold my camera for me, please? Yes. I sometimes find that we can also turn this because this goes
Very-
in. Oh, okay. So you can see the bone is just not behaving itself. Likes to do this during cadaveric demonstrations. But anyhow, we're gonna lock this and hope this stays. Okay, can I
yeah.
just have a suture cutter, please? Okay,
I think it has
okay,
come
good.
out.
So,
No, it's not holding.
nope, the anchor has come out. It's not holding. Yeah. Okay. Can this be pulled out? Have a,
Pull it out?
yeah.
Okay.
Yeah. Okay, let's have a footprint now. Maybe we just bang it in and see if it holds. Yeah, let's try a footprint anchor. Can I see a footprint?
Footprint anchor?
Yeah. Okay, I'm going to try one last time before we move on to the Regener-10. Is it okay? Yeah, so I think we just bang it down here and then we leave the suture there.
Yeah. Yeah, this is the same problem I encounter in my cases. Very
Just
awesome.
hold the camera. Thank you. Okay. Just a little bit of the sutures rather than all. Okay, great. Yep, can pull that through. Okay, great. So we're gonna try one last time with this footprint anchor and hope it behaves itself. Oh no, you can see the bone is really soft. Okay, let's try and see if we can pull this very gently, the sutures. Maybe just pull. Okay, good. I tell you
Yeah.
what, that's...
I think we can leave it.
Yes.
We won't pull it more.
Yes. Let's try and see if we can just leave it here.
Yeah. And so it will be. Oh yeah.
Okay,
Okay. Okay. Yes. Okay. Yeah.
Okay, I'm just going to leave here to assume our rotator cuff is being repaired, okay? Of course, there's a little bit of lack of tension. Okay, let's have the Regener-10 cannula. So the Regener-10 is used to augment a rotator cuff repair. It's not meant to provide structural strength in the beginning at the time zero. So it's unlike a dermal allograft that we are talking about. Okay, so let's have the cannula, please. No, no. No, not this one. There's another small blue cannula. This one. Yeah. You hold it for me. Yeah. Yes. Okay, and the good thing about the Regener-10 is it comes with the same portals that you can do. So that's my anterior superior portal, and this should reach as medial as you want it to be. Okay, and then we will need that wire, that guiding wire, if you have that wire. So yeah, our suture is a bit loose. I'm just trying to manage it without. There's a guide wire.
Should I cut those?
Yeah, I just get it pulls out again. I think we leave it there.
Yeah.
Yeah. Okay, and then there's this wire that comes right in here. Can I have a straight artery first?
I will hold it.
This portal, lateral portal, needs to be a little bit bigger because you will see that there's a very big instrument that comes in here later on. So I'm just going to make sure this portal is big. And this wire gives you a rough guide on where the regeneratant is going to end. So I'm just going to use this and put it somewhere about there. If can someone mallet this down for me? A bit harder.
Remove it?
Yeah. Oh no, just a bit harder. Just mallet it down. Okay, good. Oh no. Okay, so clearly this is not holding as well. I'm going to try one more time. Even a small wire is not holding. Let's try that again. A bit as hard as it is.
So is that the wire for the hole for the staple?
Yeah. Oh no, this is just to give you a rough idea on how medial or lateral your regeneratant can go. Okay, but you know the bone is not holding, so I'm not going to use that. Let's have the regeneratant coming in now. So it also helps to railroad the regeneratant in, but in this case I can't use it, so I'm going to put the regeneratant. So typically you want the regeneratant, you can see the end of the regeneratant, you want it to be on bone, so I'm going to keep some of these on bone. And once I'm happy there, I'm going to open this up and I'm going to deploy that regeneratant. Okay, and I'm making sure that I have regeneratant on bone. And I'm going to ask Nitesh, do you mind if you just hold this firmly for me? Yeah, just hold it for me. And that's fine. Okay, and then now I can go and use this staples and someone stabilize that cannula for me.
Yeah.
Thank you. And I'm okay. You can relax on the cannula. No, don't move don't move the one. You can let go on the cannula.
So the patches come from the lateral
portal. Yes.
And you're trying to hold it from the anterior superior.
Yes, you are absolutely right. So I'm now having a good view on this, and I'm gonna introduce these staples. So can you hold this for me? Yeah, Mitesh, I got this. Yeah. So yeah, maybe like that. Yeah. Just so that
Okay.
so I can see it. Yeah. Okay, good. Okay, wait. Just relax on this for a while. Okay, just hold this for a while. Okay. You just shifted the patch so that we push it. Okay, so maybe there. Okay?
Okay,
Yeah. Okay.
yes.
Yeah. Don't move the patch anymore.
Okay.
Okay, so the assistant's job is not to move the patch anymore because I put it in a good favorable position. And I'm
So
just going to.
how deep do you normally put this patch on to the cup?
Well, I will
How far medially?
I want it to cover my rotator cuff where the tear is because it's to augment the tear. Don't move the patch. Yeah. Can pull out the cannula a little bit, and it should be lateral enough to make sure that it sits on bone. You can let go of the cannula. Yeah. So that's me deploying the first one, and you can see me squeezing that anchor. Okay, let's have the second one.
That is the
Hold it. Hold.
So they are like the flexible staples. Right?
Yes, they are. They are made of PLLA, and they are. Yeah, I got a camera. And they are actually very fast to deploy. So that's me putting the second tendon anchor. Okay, and then let's load the third one. And you can see that we are putting it over the rotator cuff. So it's important that this patch is right over the cuff. Hold the camera.
Cannula. Cannula.
Do we have a question?
Yeah.
I don't. Dr. Raj here. So two things. I think there's the philosophy of putting the patch in two areas. One is on the cuff itself to enhance the quality, or we can put the bone clips margin on the footprint. What is your preference and how you decide where to put?
Yeah. So the ideal situation. It's okay. You don't worry about the camera. You just hold it there for me. Ideal situation is this regeneratant covers the cuff as well as it goes all the way to the bone. That's ideal. But you are absolutely right in saying that some people have described using the patch in a type 2 tear, where the tear is located a lot more medial than where you expect your standard rotator cuff. So if you're augmenting in a standard rotator cuff, it's usually not a problem because I find that you are actually you will end up in bone. That is usually not the problem. The problem comes when you are doing it in maybe a type 2 tear, and sometimes I will elect not, yeah, I got this. I'll elect not to put it on bone, but ideally I would like it on bone.
Thank you for the answer. And second part of the question is about putting the stitches there onto the collagen and the cuff. And I believe what the profile puts across is not to cross the blue edges. Even personally, I find sometimes putting on the edge of the white and the blue edge helps in rolling over. So I see your other side, it's been put more on the bluish side. So do you think it's okay to do that, or you would like to stay well within the white zone?
No, I think you can put it off the edge, it doesn't matter. Need to show this one. Yeah, I think it's reasonable to put it off the edge of the white zone, that's okay. I don't think that's really a big issue. So maybe help me press this down like that a little bit. Give me another staple. Yeah, I don't think that this makes a huge amount of difference, at least in my experience when I've been using it. I don't find that it's a big issue at all.
And you have one standard size, right?
Yeah, there's two sizes to this Regenerative 10 patch actually. So I think both, if it's a bigger tear, sometimes I've used it on the bigger patch, but generally speaking in Asians, I tend to use the smaller one. Okay, so once you have that, then I'm going to take the bone staple. Can I have a bone staple? Okay, and this bone staple comes through this lateral cannula, and so you can imagine that this is quite big, and I'm going to just unlock this, and it comes with these two metal core, and it's going to come right in there, and I'm actually putting a little bit of tension on it. Okay, and once I'm there, yeah, I'm feeling that I'm on bone. Yep, you can go ahead. Yep, keep going. Good. Stop. Yep. Okay, that's fine. Yeah, let's pull it out. Excellent. Let's have the. So this lateral row anchor is ideally sitting on greater tuberosity, except in situations where the tear is very medial, for example, a type 2 tear. Okay, and so that's okay. You can pull that out. So that's the first anchor. There's a bit of peak, and now I'm going to go to that area of soft bone. Just hold my camera for a short while, and I'm going to just internal rotate. Okay, that's enough. Yes, hold it there. Yeah, so playing around with the rotation of the bone gives you a very excellent view. So that's the second anchor, and you know, this is the area where we have quite soft bone, so I'm going to change my position a little bit. Okay, oh no, there's still very, very soft bone, so we are going to try and find a nice little place to sit this anchor. I hope, okay, maybe let's try that, yeah. Wait, let me just see. Yeah, okay, let's try that. Yeah, just gently. Okay, okay. Yeah, and then, okay, good. A bit harder?
Very nice.
Yes. Okay, good. Okay, so that's us putting in. Okay, so you can see an area of defect, so unfortunately I can't put any more bone anchors. But that's basically the concept of putting the Regenerative. So you can see it covers where our rotator cuff is. And typically it's quite stable. You can see me putting a couple of tendon anchors, and this can typically take you 10 minutes. The whole system is easy to use. You do not have to make any additional portals. I've been using the standard anterior superior portal that I put my medial anchor in with, and then followed by the lateral portal for the bone anchors. So typically I would like 2 bone anchors, but you see that's the area where we have a lot of soft bone, so unfortunately we can't really get a very good catch, but that's my second peak anchor. These 2 lateral anchors are made of peak and they do not dissolve, but the remaining tendon anchors, they are like almost like a staple. They are made of PLLA and they resolve. Again, I emphasize that this implant is not meant to provide structural strength at time 0. So it's not like a dermal matrix where you're putting it there to get strength. This is basically to provide biology. So you repair your rotator cuff and you augment your rotator cuff with this. But the good thing is at 6 months later, you get this implant completely resolved and stimulating new tendon formation. And that's been proven by several papers. And I think the latest by Ruiz Iban has shown on the RCT that it helps to reduce these retear rates for small to medium sized rotator cuff tears. Yeah. Is there any question that anyone want to ask?
Yeah, Andy, how often do you use them in clinical practice?
Yeah, that's a very good question because I started like everybody with a new implant. We will tend to be a little bit aggressive, but in Singapore I face the same situation. We have insurance coming into our picture, so I use it for tests that I'm concerned about healing, and I use that and I justify to the insurance because in Singapore we have to write to the insurance to explain why we are using a more expensive implant. And in my practice, I use in about 10 to 15% of rotator cuff repairs when I augment them. And typically it's 4 situations. Number 1, if it's a revision cuff. Number 2, if it's an immunocompromised patient, for whatever reason he's on long-term steroids, they are on immunosuppressive medicines. That second group, I put a Regeneratent, or they are smokers, and they do not want to give up smoking or they can't give up smoking. So that immunocompromised group. Third group of patients I use it in is in a patient where it is a very complex tear pattern. For example, a type 2 tear, or sometimes you get tears at the musculotendinous junction or a mid-tendon tear where you are repairing it side to side and you are concerned about the healing. I'll use Regeneratent. And then my fourth indication would be where I have a massive rotator cuff tear and I can reduce and I can repair the rotator cuff to the medial footprint, but I can't get entire footprint coverage, and of course there's a big debate on whether you then move to a SCR or you do a medialized single row repair with low tension. So I tend to do a low tension single row repair, and I augment my footprint coverage on the lateral side with the Regeneratent. So it's a single row repair with a Regeneratent. So those are my indications, or at least how I rationalize in my mind which are the patients that I think will have a high re-tear rate. And those are the patients that I use a Regeneratent.
Okay, thank you. And have you seen any complications so far with it? Like, the staples getting scarred up and...
Oh no, so that's a very good question. I'm just going to show you if you feel, give me a straight artery or a suture, a grasper. Yeah, so in case that there's a situation where you feel you have a loose anchor, I'm just going to show, since we have a bit of time, a grasper. Yeah. A grasper. If you have, let's assume I've put 5 anchors in, the whole set comes with 8, but assuming I have and I don't like this anchor and I think it's going to come out, what you can do, you can actually remove them very carefully. So I'm just going to put my thing here and I'm almost like holding it like a crocodile and I'm just going to try and pull this thing out slowly. Right? So you can actually remove them if you feel that this anchor is actually a bit loose. Yeah. So I personally have not had to re-operate on any patient with Regeneratent so far, or at least not because of the Regeneratent. One of the big concern, I think we spoke about it, I think in Ashish earlier talk, is that in Asia sometimes we see patients with rotator cuff. So that's me removing one of the loose anchors that I don't like. And of course I can replace this with another anchor if I want to. So stiffness is one concern. I think there's a paper out there talking about the increased risk of stiffness. And I think you need to be careful. I don't use it if it's a diabetic patient. We all know diabetics have a higher risk of frozen shoulder. So personally, I don't use it in frozen shoulder patients with diabetes. But so far, I've used this Regeneratent maybe about, I would say maybe 40 to 50 times. And so far, I do not have any patients with stiffness or any reason for me to re-operate on the patient. I had one patient had a bit of stiffness. And I gave a steroid injection and her stiffness improved. I did not have to re-intervene. And interestingly, when I went back and looked, and she did have diabetes, and that's the same reason why I stopped using it in diabetics.
Thank you. So the foreign material is not causing any more reaction or inflammatory process.
Do we have any other questions?
Any other questions? Can you hear us?
No, thank you. It's a good demonstration. Thank you very much, Andy.
Okay.
Okay, fine.
Okay. Thank you very much.
Thank you. Thank you.
Thanks. Okay, great. Okay, great, man.